those of you who were in Dublin 7 years ago will have seen this slide, and there's a touch of, well, I told you so, all about it, isn't there? Because times certainly have changed and are continuing to change and provide us with an enormous amount of challenges. You will probably all have also seen at some stage or another this slide or a variation of it. The difference now is that the top statement is now a statement rather than a question as it was when I first posed it. So I'm afraid that's no longer an option. The other thing which has happened fairly recently is the development of a new generation of, for the sake of a better word, I know I'm going to sound terrible, a new generation of young people. We've had Generation X, we've had Generation Y. The sociologists now tell us we have Generation Me, who have these characteristics. And I'm sure you will recognize many of them, if not in yourself, then in your children. They have a high value on worth-life balance. They are very clear about what they want and are determined to get it. They are narcissistic, which is another word for self-centered. They tend to be very conservative. That's why so many of them still live at home. They are thoroughly miserable, but they are very good with their thumbs and with digital technology, which is, I'm going to come back to that because we got badly caught out with that. So you don't have to take my word for it. It is out there in the medical education literature. So we have a different group of trainees from the old farts in the room like myself who did it slightly differently. So we're all doomed. And I would like to actually take a contrary view, not surprisingly maybe, and try and portray some of the things I think which are quite positive about the future of education in cardiothoracic surgery. When I was at the JCST, we came up with this very simple, almost simplistic logo, that the concept should be to train smarter, not just do more of the same stuff. So we try to develop ways in which we could modernise training across the whole of surgery, but in fact across the whole of medicine. And bear in mind that training is not unidimensional. It's a blended, complex blended mix of what's in the curriculum, how that is delivered by the trainer to the trainee, and what the training environment they're all working under is. And I'm going to perhaps touch on all four of those elements in the next few minutes. So, new NHS, there it is. And I would like to just focus on this thing, this yellow thing here, which is Health Education England, which replaced what was a number of bodies, but the one you mostly will be familiar with was Medical Education England. Health Education now in England is now responsible for the training, education, personal development, and that includes recruitment and workforce planning of all healthcare professionals. And it'll do this through a group of organisations, of which there are 13, called Local Education Training Boards, which will include the deaneries within them. So the deaneries aren't going away, they've just been, if you like, subsumed into these so-called LETBs. Now, it wouldn't have escaped many of you's notice that this just applies to England. And there's a whole bunch of different rules for the devolved administrations, none of which I know anything about. So if you are not working in England, some of this will not apply to you, I'm afraid. So that's what Health Education England is in a very briefly. But HE was tasked, one of its many things, was to follow up the work that Sir John Temple did in 2010, and also to a greater or less extent the work done by John Collins on his foundation review. And there are, and the third bit of work, which never really got finished properly, was the Tuck report, which some of you may remember was subtitled Aspiring to Excellence. So HEE, for whom I am now an apologist, has these three projects which I think are of relevance to what we do. The first is it has a very well-funded Better Training, Better Care project. They're running a series of pilots nationally in a whole range of medical specialties, doing a whole range of different things to try and show that if we provide better training, we can look after patients better. And there are things like using apps for handover. There's things like the use of telemedicine for complex consultations. There's the use of simulation in hepatobiliary surgery. And all these things are being piloted following an application process with the view to not only seeing if they work, but also seeing whether they are adoptable and can be rolled out across the country. So keep your eye out for Better Training, Better Care projects. There's probably one near you, and hopefully they will see some changes and some developments. The other thing which I'm personally very interested in and quite heavily involved in is technology-enhanced learning. HEE has now taken over the old e-learning for health group, and is now developing, as per the Temple Collins and the CML's report, a lot, major interest in simulation, and very soon we can rest assured there will be an app for just about everything. So all these things are going on, and next week, or is it? No, it's this week. This week there is actually the first meeting of the Technology Enhanced Learning Work Group, and we are working in conjunction with the Higher Education Academy to develop a strategy for technology enhanced learning. And the final thing is a review of the shape of training being organised by Professor Greenaway, who's an economist, I think, from Nottingham, in conjunction with the GMC. And this is a complete roots and branches review of medical specialism versus generalism. And how many generalists do we need? How many specialists do we need? What is the shape of medical training going to look like in the next few years? And the Society, I know, has actually made contributions to that consultation. That's just to remind you, or if you've not seen it before, to show you what the framework for technology-enhanced learning and how it is patient-centred, but also has to be educationally coherent. This is a little bit on simulation. This is the setup which Jim Fan has in Stanford. It's clearly an outstanding facility. And this is your lot in Seattle. This is Ed Verrier's group in Seattle with some very nice bits of kit here, very sophisticated, very expensive simulation things. But it doesn't, with beating pig hearts and all that sort of thing. It doesn't have to be like that. We've had wet labs in this country, in this specialty, for as long as I've been around, probably about 20 years. Some units like ourselves have permanent wet labs for trainees to go to at their convenience. But then there are other things which we as a specialty have developed in terms of simulation over a number of years. And I suppose many of you will have seen this particular model, which we developed at the College of Surgeons about 10, 15 years ago. And as David will tell you, there are other ways of doing simulation using all sorts of, we call it the Delia Smith approach to surgical training. So simulation is out there. The trouble with it is we need to do things to make it work. We don't have properly established regional or national networks. We don't have the resources we think we need, and I look kind of jealously at what Ed's group in Seattle and James Fan's group in Stanford are able to do. And one of the things which we really struggle with, and I've personally experienced this, is getting people to work as faculty, getting people to take time away from clinical duties to develop this aspect of training. Two things there, though. I think we need to congratulate people like David McCormack for setting up, or helping to set up, the boot camp for surgical trainees, which was very kindly sponsored by Sorin. And I think that is a way which we will have to be going in the future and engaging more and more with our industry partners to help establish these types of activity. So simulations, high on the agenda, will continue to be high on the agenda, but it needs to be, and I said this last year for anyone who's listening, we need to sort of make it a bit more coherent and integrated. One of the things we have to do is put simulation on the curriculum. That submission has actually gone to the GMC for all surgical specialties today, actually. So there will be simulation written into the curricula, which brings me on to this. Many of you remember when the ISCP was first introduced, it was a dog's dinner, I think it's fair to say. The nicest thing anyone could say about it was that the website is clunky. I think hopefully in my time at JCST we have turned the ISCP around, and it is now a very valuable tool and a very useful platform for surgical training. But one of the things we found out quite early on was that to deliver innovative new training techniques, you need to take not only the trainees with you, but also the trainers. And one of the real issues around ISCP was that we didn't have the trainers to deliver it. We had the Training the Trainers course, and we then went on to develop the Training Assessment in Practice course, which kind of filled those gaps. But it's become clear to us in what we do, and became clear to the GMC, thankfully, this year, and they have now developed a process for recognition and accreditation of proper medical trainers. And that is, if you want to be a trainer, you should be able to demonstrate to the GMC that you fulfill their criteria, you put it on your appraisal, you put it on your revalidation, and you get it on your job plan. So there's the opportunity there to be recognised, or to have your training not only recognised, but also can we develop it further? What do we need to do to make to increase the skills of our surgical trainers? Some of you might have seen this last year. This is the seven characteristics we drew out of David's silver scalpel work. We've in the year that's been since we first put this up as a hypothesis, we've now tested this using a thing called constructivist grounded theory. And if anyone's interested in that, I'd love to share it with them, because it really is fascinating, that sort of thing. The analysis of qualitative data is a real eye-opener. But we have now, in the same way as Covey had his 7 habits of highly effective people, we now have 7 behaviours of great trainers. And what are we going to do with it? We are going to continue with our programme of Leaders Educator programme. I'm very pleased to say that we've had another educational grant from Edwards Life Sciences, and Care Fusion have also generously donated some money. So this is a bit of an advert. I would like to speak to anyone who's interested in joining this programme for later in the year, because we would like to see a fully trained educational guru in every single cardiothoracic centre in the UK. Someone who understands all these sort of concepts of education, training and learning. These are the messages we're going to try and get across to help turn people into great trainers. And that briefly is the outline. But anyone wants to explore this further, please come and have a chat with me. Throughout your career, there will be enhanced training opportunities. We now have a very well-established research program through NIHR and other funded organisations. There are clinical leadership fellowships out there for people who are interested in that. There are educational fellowships. We are increasingly, and this is across the whole of surgery, developing peri or post-CCT fellowships. And we'll hope, as John Pepper mentioned it yesterday, and I think it's absolutely right to talk about continuing development for established surgeons. Kind of brings me on to my second last slide, and that is the CTS University as scholarships, which have been very generously funded by Ethicon, and we can't thank them enough for their support, and it's a good amount of money. So we had some applicants for that. We scored them, and I'm here to announce that the 4 winners of these scholarships this year are Tom Barker, who's going to Brussels to work with Al Khoury and do some advanced valve surgery. James Barnard, who's going to do some lung transplantation in Toronto. Mick Murphy, who's as adventurous as ever, is going to stay in London but do some congenital surgery. And Paul Vaughan, who thinks he's going to travel around the whole of the United States in 6 weeks to do some advanced thoracic surgery. So congratulations to those people, and thanks very much to Ethicon once again. I just have to finish by reminding us that this is the Society for Cardiothoracic Surgery. It's not the Society of Cardiothoracic Surgeons anymore and hasn't been for a long time. We are an inclusive group, and as I finished preparing this talk, I realized I had concentrated on postgraduate medical education. This society and its educational subgroup has much broader remit than that. And as I stepped down as Education Secretary yesterday, we looked at the to-do list for that group and realised there's an enormous amount of work that needs to be done, particularly for allied healthcare professionals. And I was very pleased to see today that we've appointed both Rajesh Shah and Mike Lewis to co-chair that group, because I think there's an enormous amount of work to be done there. So that's all I've got to say. I'm sorry I've overrun by a little bit, but I'm sure Ed doesn't mind. And I'll finish there. Thank you.